So how to detect the exact branch of the portal vein that is thrombosed? So this is the main portal vein. How to detect the main portal vein? The main portal vein is seen at the confluence of the splenic vein and superior mesenteric vein, and is seen here. This is the confluence, okay? And the confluence here is enhancing, okay? The portal vein here is enhancing. Okay, so the first vertical branch and upwards branch is the left portal vein. Okay, so let's see that here. This is the first vertical and upward branch. Okay, and it is thrombosed here. There is filling defect here in the left portal vein branch. The vertical and upward branch is the left portal vein branch. The vertical and upward branch. Okay. So the left portal vein branch is not enhancing here, and there is a filling defect. This is the normal enhancement. There is a filling defect in the left portal vein branch with 67 Hausfeld unit. Okay, so this is suspected to be a thrombus, and the T2 weighted MRI confirmed that this filling defect is a thrombus, because this is the normal signal void seen inside the normal vessel. Okay, this is high signal of the thrombus. The only horizontal branch of the portal vein, you will see it like this, is the right anterior branch, right anterior portal vein. Okay, here, this is the horizontal branch. Here, this is the right anterior portal vein. The right anterior portal vein. Horizontal branch is the right anterior portal vein. Okay, so the right anterior portal vein here shows hyperdensity. There is a hyperdensity signal in its lumen. This could be contrast. This could be a calcified thrombus. Look here. On T2 weighted MRI, confirmed that this is not contrast. This is not normal vessel. This is a thrombus. So this is a calcified thrombus. A calcified thrombus. Okay. The vertical and downwards branch is the right posterior portal vein. This is the horizontal branch. If you see a vertical and downward branch coming through it, this is the right posterior portal vein. This is the right posterior portal vein. Okay, the right posterior portal vein is not enhancing. Okay. So these vessels are not enhancing. These vessels are not enhancing. These vessels are not enhancing. However, these vessels contains a calcified thrombus. These vessels also contain thrombus, but it is not yet calcified. Okay. So this is the vertical branch. Vertical downward branch is the right posterior portal vein. Here, vertical downward branch, right posterior portal vein. Vertical downward branch right posterior portal vein. Right posterior portal vein. So the right posterior portal vein on MRI should show the signal void. Here there's a thrombus. Non-calcified. The right posterior portal vein is non-calcified. Is not the right posterior portal vein is not enhancing here. This is the normal enhancement. This is the non-enhancing vein. So let's see another example. Yeah. No, this is not another example. Here. This is the main portal vein. Okay. Can you see this branch? This branch is vertical and downward branch. So this is the right posterior portal vein. Okay. Vertical and downward branch, right posterior portal vein. The right posterior portal vein here is seen thrombosed. Doesn't show enhancement. Can you see the right hepatic vein? This is the right hepatic vein. This is not the right hepatic vein. This is the right posterior portal vein. Okay, here. It's non-enhancing. The right posterior portal vein is not enhancing here. Okay. So this is how to detect the branch of the portal vein. Okay, after that we'll talk about after detecting a portal vein thrombosis, what to do? Look for the cause of the thrombosis. You need to look for hepatic abscess. So once you detect a thrombosis, portal vein thrombosis, look for hepatic abscess as a cause. Okay, so we need to look for hepatic abscess as a cause. Okay, hepatic abscess can be small and can be large. Okay, so a smaller hepatic abscess doesn't show enhancing wall or halo of edema. However, the larger hepatic abscess shows halo of edema and enhancing wall. Okay, so here in this case, there are multiple collections, multiple small cystic lesions or multiple small collections within scattered through the liver. Okay, so we need to look for the hepatic abscess as a cause. Okay, then here the hepatic abscess. Okay, this is the hepatic abscess. This is the larger hepatic abscess, and this is the small multiple abscesses. Okay, so small hepatic abscess show hypodense collections only. However, larger abscess will show thick enhancing wall and surrounding halo of edema. In this case, there are innumerable small cystic lesions in the liver showing fluid signal intensity on T2 weighted images. It is seen mainly in the central part of the liver. Okay, so these lesions seen mainly in the central part of the liver. Mainly. However, there are some lesions are seen in the peripheral part, but involving the central part of the liver, denoting that these lesions are related to the biliary system. Okay, so these lesions are related to the biliary system, clustering around the central as well as the peripheral bile ducts. These lesions are clustering around the biliary ducts. Okay, this is the same base of the main difference between pneumobilia and portal vein gas. Pneumobilia, the air will be seen involving the central, mainly the central part of the liver. However, portal vein gas will seen extending to the peripheral part of the liver. So here, this is the example of a large hepatic abscess in the left segment, in the left hepatic segments, seen involving the left hepatic segments. Okay, how to know the hepatic segment? I will tell you a secret. Okay, so at the level of the caudate, if you see the caudate, the caudate is the first lobe of the liver. So I can see 1, so this is 2, and this is A. If you see the caudate, so this is 2 and this is A. If you can see the caudate, I can see 1. So there is no 2 and no A. There is 4B56. 4B56. Okay. So if you see 1, so this is 2, this is 4A, this is 8, 7. Here this is 1. So this is 2 and 4A. And this is 8 and this is 7. Okay. 8 is the dome of the liver. And you will notice that most hepatic abscesses tend to involve the dome of the liver. Okay. Because it's related to the kidney. It's related to the lung. The dome of the liver, because it's related to the lung. So especially in amoebic abscess, tend to extend from the lung to the liver. So it will be involving this part exactly. Okay, so this is an example of the larger hepatic abscess, and this is not hepatic abscess. This is a part of the portal vein thrombosis, and this is the hepatic abscess. Okay, it has thick wall, and this is the fluid intensity, central fluid intensity, and thick wall. Okay. Another example of hepatic abscess here. Fluid collection with thick enhancing wall surrounded by a halo of edema. Okay. Another example of hepatic abscess. Look here at these abscesses. They tend to involve the peripheral parts of the liver. They tend to involve the peripheral part of the liver and not the central part as the previous lesion. Okay. So I think these lesions are not related to the biliary system. Okay. So these lesions are hypodense collections with enhancing wall and surrounded by halo of edema, the characteristic features of hepatic abscess. Okay, and these abscesses are the cause of the portal vein thrombosis. That's why I mentioned if you see portal vein thrombosis, look for hepatic abscess as a cause. Okay, and these lesions tend to involve what? These lesions tend to involve the dome of the liver, its hepatic segment. I can see one, I can see the codate. So this is 2 and this is A, 2 for A, and this is 8 and this is 7. Okay. Okay. So after diagnosing a hepatic abscess, what to look for? Look for the cause. Look for evidence of cholangitis. Evidence of cholangitis. Look for any direct signs, any direct signs of cholangitis or indirect signs of cholangitis. The direct signs of cholangitis here is the presence of stones inside the intrahepatic bile ducts or air inside the intrahepatic bile ducts. Means that this duct is infected. There's infection inside this duct forming, there's an organism forming air and stones. Stone and air forming infection. Okay, so the formation of intrahepatic bile duct stones is called hepatolysis. The presence of gas inside the intrahepatic duct is called pneumothelia. Both are signs of cholangitis, pyogenic cholangitis. Okay, so if you can see these signs, if you couldn't see the direct signs of pyogenic cholangitis, look for the indirect signs of cholangitis. What are the indirect signs of cholangitis? Biliary obstruction and biliary stasis. Okay, these are the indirect signs of cholangitis. Biliary obstruction and biliary stasis. Biliary duct dilatation, as in this case. Okay, in this case, the reason of the hepatic abscesses, is the biliary obstruction and biliary stasis that leads to ascending cholangitis. So here there is intra and extrahepatic, intra and extrahepatic bile duct dilatation. How to know the bile duct dilatation? Common bile duct and the common hepatic duct should be less than 7 millimeter. If you measure the common bile duct 10 millimeter, it's above 7, so there is bile duct dilatation. Here, in this case, the bile duct dilatation is down to the level of the distal common bile duct or the ampulla. So this is common bile duct obstruction with intrahepatic biliary radical dilatation. Okay, so if you found hepatic abscesses and you try to look for direct signs of cholangitis, no, there is no direct signs of cholangitis. You try to look for any signs of hepatic, any signs of intra or extra, you can't find any signs of biliary ductal obstruction. So what to do? Okay, look for a history of surgery. Look for the history of surgery as hepatic abscess could be a sign. Um, if you can see any cause, any radiological cause of the hepatic abscess, look for the history. Look for a history of post-cholecystectomy surgery, as this is a common complication of the surgery. Okay? Okay. So, as I mentioned, the biliary obstruction has resulted in ascending cholangitis, which resulted in hepatic cholangitis microabscesses, which resulted in portal vein thrombosis. So, that's all.